After giving antifungal treatment, you have to control the fungus first, and if you do not control it, it will flare up and will give more trouble. On the medical side, we feel that the treatment for fungus should last for at least 2 weeks. Otherwise, recurrence chances are more. I don't know what homeopathy believes. You have to give antifungal ear drops. The most common one that is there is clotrimazole, available as Candid and all that. And the third method of removing wax is by suction. Now for suction also you have to insert the tip of the suction into the ear. So in a sitting patient, again the same danger of damaging. Yeah, if you have the patient is in the operation table, lying down, has been calmed down by sedation, then we use the suction because that is one of the best ways to clean the ear. As far as the foreign body is concerned, that can also be syringed out. But if it's a hygroscopic foreign body, you should not. Because the foreign body can be living, it can be non-living. Living foreign body will create you have to kill the living foreign body, and the simplest thing is if you don't have anything, pour water in the ear. It will get suffocated, it will die. And then it becomes like a non-living foreign body which you can syringe out, or with the help of a wax hook or a vectis, you can take it out. You have to go behind the foreign body and pull it out. That is the way you can remove the foreign body. Polyps, you have to excise them. Granuloma, you have to remove it. Myringitis will require antibiotics and anti-inflammatory to bring it down, drops also, and then cleaning the ear. Sometimes the granulations may have to be scraped out also surgically. If there is any neoplasm, etc., then of course the treatment becomes removal of it. In the middle ear, for perforation, you must be aware that the perforations are of two kinds, the benign and the dangerous. Benign, the correct word is tubotympanic perforation. Dangerous is aticoantral perforation. If you see the eardrum, if the perforation is surrounded by the eardrum on all sides, the perforation is surrounded by the eardrum on all sides, that is a central perforation. And attic or marginal perforation, attic perforation is in the uppermost part of the eardrum. And there it is not surrounded by the perforation, the eardrum on sides. Similarly, the marginal, there also it will not be. The treatment from the deafness point of view, the treatment is tympanoplasty. Tympanoplasty, in simple words, is the repair of the eardrum. The eardrum has 3 layers, the outer layer, the fibrous layer, and the inner layer. So what you do is you separate the layers, either the outer layer and you overlay a graft on the perforation. And the graft which is taken is from the tissues from behind the ear, that is temporal fascia. That is one of the best grafts that we have found. Besides that, of course, it can be grafted with other things also, vein and facial atta and other things, but this is available in the incision there only. Then you can use perichondrium taken from the cartilage. And then there are of course the homografts also, but that is not required for that. But if there is an attic perforation or posterior marginal perforation, these are the ones which are associated with cholesteatoma. And the cholesteatoma behaves, it's not a tumor, but it behaves like a tumor. It goes on gradually eroding the bone and goes on expanding. And in that process, the neighbors get affected. Suppose I go on enlarging, the first thing I'll damage will be this computer, then you people, then that, and finally the wall. That's exactly what happens. That it goes on enlarging. First it will break the the thin wall of the skull. Then it will break through the dura. After the dura, it will break through the meninges then it will break through into the brain and you can get brain abscess also. It can go into the labyrinth, it can go into the facial nerve, all those complications are possible. So because of that, it is always suggested that the cholesteatoma has to be removed. And that is done by doing mastoidectomy, modified or radical or still further modified. And nowadays we combine mastoidectomy with tympanoplasty to try to improve the hearing also. That becomes tympanomastoidectomy. The results of plain tympanoplasty, and yes, it requires correction of the ossicles also, that is called ossiculoplasty. The results of tympanoplasty, you can achieve perforation closure if performed properly under the microscope in almost 95 to 99% cases depending upon the surgeon. The lesser the experience, the lower will be the chances of, but everybody develops experience. So I told you that overlay technique, there is underlay technique, which is that you separate the inner layer of the eardrum from the fibrous layer and you put the graft over there. That becomes the underlay technique. As far as the hearing is concerned, tympanoplasty will give improvement in about 90 to 95% cases. The improvement can come. Tympanomastoidectomy, where there has been a damage by the cholesteatoma, the idea is to exteriorize the disease. So we open everything and we keep it in such a way that through your ear canal you should be able to directly see the whole mastoid cavity. And you can inspect it, it can drain. So once it remains exposed to atmosphere, then the cholesteatoma stops progressing. Results, you can achieve dry ear in majority of the cases, but occasionally those majority patients will also get the discharge from the ear, which is not so with tympanoplasty. As far as the hearing is concerned, the results are little lower than the tympanoplasty proper. In the middle ear, the other thing that happens is autosclerosis. The bone, that is the stapes, gets fixed, and once the stapes is fixed, we don't know any medicine which will make it move. You have any medicine? No. We can move that by removing it. So you have to go up to the eardrum. The eardrum is lifted up like a veil. You expose the middle ear, all done under the microscope. Reach up to the stapes, remove the stapes, that is stapedectomy, and replace it by an implant. And that implant is Teflon piston. So this is stapedectomy with Teflon piston grafting. Excellent result. On the operation table, the patient starts hearing, because this operation usually is done under local anesthesia. Tympanoplasty can also be done under local. Tympanomastoidectomy can also be done, but since the surgery is much more extensive, probably it is better to do under general anesthesia. And the hearing, the patients who have undergone stapedectomy even 40 years back continues to hear. The only thing what happens is that as they advance in the age, they can also develop the senile deafness, which is the sensory neural deafness. And as such, the autosclerosis is a disease which affects both sides, that is the ossicles, and it also spreads to the cochlea. So you get combined deafness, and finally later it becomes sensory neural deafness only. And eustachian tube problems, at present they are difficult to treat, but basically I can say that if you take care of the nose, throat, all the diseases like adenoids, and if there is an allergy, that has to be kept under control. Allergy cannot be cured but can be kept under control. And as far as the septum is concerned, the only thing is that if you give tablets, it is controlled for only a day. If you use steroid spray, it will be controlled for 15 days to more weeks. And if you give, I have been performing also that chemical cautery with silver nitrate. That gives results for about a year or two. But after that, the thing will come back. Deviated septum, polyps, etc., whatever are there have to be corrected. So that way you can take care of the middle ear. The inner ear, we have the defects, which is